Welcome to Copilot Podcasts. Picture this. You blink and a navigation arrow appears floating in your field of view. You glance at a stranger and their name and LinkedIn profile materialize beside their face. You look at a restaurant menu and calorie counts auto-populate next to every dish. That is not a scene from a Netflix sci-fi series. That is the destination that ocular implant researchers are actively engineering toward right now. Today, we are unpacking the SKYGATE concept and the future of ocular implants. Specifically, what SKYGATE actually means as a technological framework, how the engineering of eye-integrated displays has evolved, and what the next generation of retinal and subretinal implants could realistically do for both people with vision loss and eventually for all of us. I've got someone here who has gone deep into the source material on this, and I want to start with the most basic question that I think a lot of people are going to have.
So what even is a SKYGATE? Is that a brand name, a concept, a category of device?
So the SKYGATE framing is really a conceptual architecture more than a single product. Think of it as a threshold, a gate, between the biological visual system and a digitally augmented information layer. The idea is that the eye itself becomes the interface point, the gateway, where physical photons and digital data streams converge. And the evolution of that concept tracks pretty closely with the broader history of smart contact lens and ocular implant research.
Okay, so it's less like a specific gadget and more like a design philosophy for how we think about integrating digital information into vision.
Exactly. And what makes it interesting is that the SKYGATE concept has evolved through several distinct phases. Early iterations were essentially about passive enhancement. Think corrective lenses that also had embedded sensors for health monitoring, like glucose detection through tear fluid. That was the first generation of thinking, the eye as a sensor platform.
Right. I remember reading about smart contact lenses that could monitor blood sugar levels for diabetics by analyzing tears. That felt like science fiction when it first came out.
And that research was genuinely groundbreaking because it proved that you could embed functional electronics into a form factor that sits directly on the cornea without causing immediate harm. But the SKYGATE evolution goes much further than sensing. The second phase is about display, actually projecting information onto the retina or into the visual field. And that is where things get dramatically more complex from an engineering standpoint.
How complex are we talking? Because I feel like people hear projecting onto the retina and they imagine it's just like a tiny projector you stick in your eye.
Yeah, it is so much more involved than that. There are actually several distinct engineering problems that all have to be solved simultaneously. The first is power. How do you deliver enough energy to run a display system inside or on the eye without wires crossing the cornea, which would be a massive infection risk, and without generating heat that damages ocular tissue? The second problem is data transmission, getting information in and out of the device wirelessly at sufficient bandwidth. The third is biocompatibility. The materials touching the eye or implanted near the retina have to be stable over years or decades without triggering immune responses or degrading.
And then presumably there's the actual display problem on top of all that.
Exactly. And that fourth problem is arguably the hardest. If you're talking about a contact lens display, you need micro LEDs or similar emitters that are small enough to fit on a lens, bright enough to be visible in daylight, and arranged in a way that produces a coherent image without interfering with natural vision. If you're talking about a subretinal implant, something placed behind the retina, you're trying to electrically stimulate photoreceptors or retinal ganglion cells with enough precision to generate recognizable visual patterns.
Wait, so subretinal implants are literally sending electrical signals to the cells in your retina to make you see things? That's the core principle, yes. And there's actually a really instructive parallel here to cochlear implants. Cochlear implants work by bypassing damaged hair cells in the inner ear and directly stimulating the auditory nerve with electrical signals. The brain learns to interpret those signals as sound. Retinal and cortical visual implants are attempting something analogous, bypassing damaged photoreceptors and stimulating the visual pathway directly. The cochlear implant went from radical experimental concept to standard clinical practice over a few decades, and researchers in the ocular space are hoping for a similar trajectory.
That's a really useful frame. And it also kind of explains why this feels simultaneously very far away and closer than we think.
Precisely. And the stakes are enormous when you look at the numbers. According to the World Health Organization, at least 2.2 billion people globally have some form of vision impairment, and of those, at least 1 billion cases are preventable or have not yet been addressed. Conditions like age-related macular degeneration, retinitis pigmentosa, and diabetic retinopathy destroy the photoreceptors that ocular implants are specifically designed to replace or bypass.
2.2 billion. That's not a niche medical problem. That's a significant chunk of humanity. Right, and that's what gives the medical case for ocular implants such urgency. But here's where the SKYGATE concept becomes philosophically interesting, because the same technology that could restore functional vision to someone with retinitis pigmentosa could, in a more advanced form, give a person with perfectly healthy eyes capabilities that go beyond normal human vision. And that's a very different conversation.
Yeah, that's the jump from therapeutic to enhancement, which is where things get ethically complicated fast.
Exactly. And the SKYGATE framing is useful here because it acknowledges that the gate swings both ways. It's a threshold that, once crossed for medical purposes, becomes very difficult to close off for enhancement purposes. The engineering infrastructure is the same: the miniaturized electronics, the wireless power delivery, the biocompatible materials. What changes is the application.
Okay, I want to come back to the enhancement question, but first, can you walk me through what current ocular implant technology actually looks like? Like what exists right now versus what's still in the lab?
Sure. So the most clinically established technology in this space is the epiretinal implant, devices that sit on the surface of the retina and stimulate retinal ganglion cells. The Argus 2, developed by Second Sight Medical Products, was one of the most prominent examples. It used a camera mounted on glasses to capture images, process them externally, and then transmit its signals wirelessly to an electrode array on the retina. Patients with severe retinitis pigmentosa could perceive light patterns and in some cases navigate environments.
So it wasn't restoring full vision, more like giving people a functional sense of light and shape.
Correct. And that's actually a really important distinction because it highlights the resolution problem. Current electrode arrays have relatively few stimulation points. We're talking dozens to a few hundred electrodes, and each electrode stimulates a cluster of cells rather than individual photoreceptors. The visual cortex has millions of neurons dedicated to processing visual information. So the gap between what current implants can deliver and what constitutes normal vision is still enormous.
So it's like the difference between a 16-pixel display and a 4K screen. That's actually a pretty apt analogy. And the research trajectory in the SKYGATE evolution is fundamentally about increasing that pixel count, developing electrode arrays with thousands or eventually millions of stimulation points, each capable of targeting individual or small clusters of neurons with high precision. Some of the most promising work involves flexible electronics that can conform to the curved surface of the retina without causing mechanical damage.
Flexible electronics on the retina, that sounds almost impossibly delicate. It is extraordinarily challenging. The retina is about 0.5 millimeters thick and incredibly fragile. Any implant that contacts it has to be soft enough not to cause mechanical trauma, stable enough to maintain electrical contact over years, and biocompatible enough not to trigger the kind of inflammatory response that would scar the tissue and defeat the purpose of the implant. Researchers have been exploring materials like parylene, a flexible polymer, and more recently, hydrogel-based substrates that more closely mimic the mechanical properties of biological tissue.
Hydrogel, like the material in soft contact lenses?
Related family of materials, yes. And that's actually one of the conceptual bridges in the SKYGATE evolution. The materials science developed for comfortable contact lenses is informing the design of implantable devices. The goal in both cases is something that the body essentially forgets is there.
Okay, so let's talk about the power problem, because that one really puzzles me. How do you power something inside someone's eye?
So there are a few approaches being explored. The most common in current implants is inductive wireless power transfer, essentially the same principle as wireless phone charging, but miniaturized. A coil outside the body transmits power to a coil inside the eye or near it, and that power runs the electronics. The challenge is efficiency. You lose a lot of energy in the transfer, and the receiving coil has to be small enough to fit in or near the eye without being obtrusive.
And heat is a concern there, right? Because inefficient power transfer means wasted energy, which means heat.
Absolutely. The eye is actually quite sensitive to temperature increases. Even a 1 or 2 degrees Celsius rise in retinal temperature sustained over time can cause damage. So the thermal budget for any ocular implant is extremely trite, and that constrains how much power you can actually use for computation and stimulation. Some researchers are looking at photovoltaic approaches, essentially tiny solar cells on the implant that harvest energy from light entering the eye, which is elegant because the device is powered by the same light it's trying to process.
Oh, that's genuinely clever. The light that you're trying to see is also powering the device that helps you see it.
It's a beautiful design principle. And there's a Stanford research group that has been working on photovoltaic retinal implants that use near-infrared light projected from goggles to power subretinal photodiode arrays. The goggles capture the scene with a camera, process it, and then project an infrared version of the image onto the implant, which both powers the device and encodes the visual information. It's a really elegant closed-loop system.
So the goggles are doing the heavy computational lifting, and the implant is just the final interface to the retina.
Exactly. And that division of labor is actually a really important design principle across the SKYGATE evolution. You offload as much computation as possible to external hardware, because external hardware can be larger, more powerful, and more easily upgraded. The implant itself just needs to be the reliable, biocompatible interface. Think of it like the relationship between a smartphone and a Bluetooth earpiece. The phone does the processing, the earpiece is just the output device.
That's a really useful way to think about it. And it also suggests that as external processing gets more powerful, which it will, given the trajectory of AI and chip design, the implant doesn't necessarily need to be upgraded. The intelligence lives outside.
That's a key insight, and it's one of the reasons some researchers are optimistic about the near-term clinical potential of these systems, even before the implant technology itself is fully mature. You can improve the experience significantly just by improving the external processing pipeline, better image recognition, better scene understanding, better mapping of visual information to retinal stimulation patterns.
Okay, I want to bring up something that I think is worth sitting with for a second. You mentioned retinitis pigmentosa and macular degeneration as the primary medical targets. Can you give me a sense of what it's actually like for someone living with one of those conditions, and what even a first-generation implant could mean for them?
Sure. Retinitis pigmentosa is a genetic condition where the photoreceptors, the rods and cones, progressively degenerate. People typically start losing peripheral vision and night vision, and over years or decades, the visual field narrows until many patients are left with only a small central island of vision or are completely blind. The inner retinal layers, the ganglion cells that the implant stimulates, often remain intact even as the photoreceptors die, which is exactly what makes epiretinal and subretinal implants viable for this population.
So the wiring is still there, the photoreceptors are just gone.
Exactly. And for someone who has been completely blind for years, even the ability to detect light and dark, to perceive the outline of a doorway or the presence of a person in a room, that is genuinely life-changing. There are documented cases of Argus 2 recipients who could navigate hallways independently for the first time in years, or who could see the outline of a family member's face. It's not high-definition vision, but the functional and psychological impact is profound.
That really puts it in perspective. We're talking about someone seeing the shape of their child's face for the first time in a decade.
And that's the human reality behind all the engineering complexity, which is also why the field has attracted serious investment and research attention, despite the enormous technical challenges. The unmet need is real, and the potential impact is enormous.
Let's shift to the future concept side of this, because I think what a lot of people are curious about is, where does this go beyond restoring lost vision? What does the SKYGATE look like in its more advanced iterations?
So the conceptual roadmap in the SKYGATE evolution moves through several stages. After restoration comes enhancement, giving people with healthy vision additional capabilities. The most discussed near-term enhancement concept is augmented reality overlays delivered directly to the retina, bypassing the need for external glasses or headsets. Imagine having navigation information, translation of foreign text, or identification of objects appear in your visual field without any visible hardware.
Which is basically what AR glasses are trying to do right now, just without the glasses.
Right, and the advantage of doing it at the ocular level rather than with external optics is significant. External AR systems have to deal with the optics of projecting an image that appears to be at a comfortable focal distance, they have to account for the user's head movements, and they're visible to everyone around the user. An ocular implant that stimulates the retina directly sidesteps all of those optical challenges. The image is generated at the source, so to speak.
Although I imagine that creates its own set of challenges around how the brain integrates that artificially generated signal with the natural visual input it's receiving simultaneously.
That's one of the deepest open questions in the field. The visual cortex is extraordinarily good at integrating information from both eyes and from different parts of the visual field into a coherent percept. But it's not clear how it would handle a situation where part of the visual field is natural photoreceptor input and part is electrically stimulated artificial input. There could be perceptual conflicts, adaptation effects, or entirely unexpected emergent experiences. We genuinely don't know yet.
That uncertainty is kind of fascinating and kind of terrifying at the same time. It's both. And it's one of the reasons why the research community is very cautious about moving from therapeutic applications to enhancement applications. With a therapeutic implant, you're giving someone something they've lost. The risk-benefit calculation is relatively clear. With an enhancement implant in a healthy person, you're introducing risk into a system that's already functioning well, and the unknowns are much larger.
Okay, here's a question I've been sitting with. You mentioned that the SKYGATE concept represents a philosophical shift, the eye going from passive receiver to active interface. Can you unpack that a bit more? Because I think that's actually the most interesting part of this whole conversation.
So throughout human history, the eye has been understood as a receiver. It takes in light from the world and converts it into neural signals. It's fundamentally passive in the sense that it doesn't add information to the scene, it just captures what's there. The SKYGATE concept inverts that relationship. If you have an ocular implant that can overlay digital information on your visual field, the eye becomes an output device as well as an input device. It's no longer just receiving the world, it's also displaying a layer of information on top of the world.
And that layer could be different for every person. Two people standing in the same room could literally be seeing different versions of reality. Exactly. And that raises profound questions about shared reality, about privacy, because if your visual field can display information about the people around you, what data is being collected to generate that information? And about identity. If your perception of the world is mediated by a device that can be updated, hacked, or controlled by a third party, what does that mean for your autonomy as a perceiving subject?
The hacking angle is one I hadn't fully thought through. Like, if your vision is running on firmware, someone could theoretically push a malicious update.
It's not a hypothetical concern, it's something that security researchers in the medical device space are already raising. Pacemakers and insulin pumps have been demonstrated to be vulnerable to wireless attacks. An ocular implant with wireless connectivity would face the same class of vulnerabilities, and the consequences of a compromised visual implant could be severe, from displaying false information to potentially causing harmful stimulation patterns.
So, the security architecture of these devices is as important as the biomedical architecture.
Absolutely. And this is an area where the field is still quite immature. Most current implant research is focused on the core biomedical challenges, getting the device to work safely and effectively, and security is often treated as a secondary concern. But as these devices become more connected and more capable, security has to be a first-class design requirement, not an afterthought.
Let me ask you about the regulatory landscape, because I imagine getting any of this approved for human use is an enormous hurdle.
It's one of the most significant bottlenecks in the field. Ocular implants are Class 3 medical devices in the United States, which means they require the most rigorous level of FDA review, pre-market approval, which involves extensive clinical trial data demonstrating safety and efficacy. The timeline from early prototype to approved device can easily be 15 to 20 years and cost hundreds of millions of dollars. That's a significant barrier to entry that limits which organizations can realistically pursue this work.
Which probably explains why a lot of the most ambitious work is happening in academic research labs rather than commercial companies.
Partly, yes. Although there's been growing commercial interest, particularly as the broader neurotechnology space has attracted investment. Companies working on brain-computer interfaces have helped normalize the idea of implantable neural devices, and some of that investment and regulatory learning is flowing into the ocular implant space. But the path to market is still long and expensive.
What about the cortical visual prosthesis angle? Because I've heard about devices that bypass the eye entirely and stimulate the visual cortex directly. How does that fit into the SKYGATE picture?
Cortical visual prostheses are actually the most ambitious end of the spectrum. Instead of stimulating the retina, they stimulate the visual cortex in the brain directly. This approach could theoretically restore some form of vision even in people who have lost their eyes entirely or whose optic nerves are damaged, conditions that retinal implants can't address. Orion, developed by Second Sight, and the work coming out of groups like the Beauchamp Lab at Baylor College of Medicine have demonstrated that cortical stimulation can produce visual percepts called phosphonenes, flashes of light in blind individuals.
So you're essentially writing directly to the brain's visual processing system.
That's the concept. And the resolution challenge is even more acute there because the visual cortex is organized in a complex topographic map, and stimulating it with enough precision to produce recognizable images rather than just scattered flashes requires electrotrode arrays with thousands of contacts placed with extraordinary accuracy. But the potential is also greater. If you can write to the visual cortex with sufficient resolution, you're not limited by the biology of the retina at all. You could theoretically display any information directly in someone's visual experience.
Which brings us back to the SKYGATE as a philosophical concept, because at that point, the gate isn't in the eye anymore, it's in the brain itself.
And that's where the SKYGATE evolution ultimately points. The eye is the most accessible entry point into the visual system, which is why it's the focus of near-term research. But the long-term trajectory of this technology is toward deeper integration with the neural substrate of vision, and potentially with cognition more broadly. That's a much longer timeline and a much more complex set of challenges, but it's the direction the conceptual roadmap is pointing.
Okay, I want to make sure we give people a realistic sense of timeline here, because I think there's a tendency in tech coverage to either say, this is 20 years away, or this is happening right now, and neither is quite right. Where are we actually?
So the honest answer is that we're in a period of genuine scientific progress, but significant remaining distance from the most ambitious applications. For therapeutic retinal implants, restoring some functional vision to people with conditions like retinitis pigmentosa, we have proof of concept in humans and ongoing clinical development. The challenge is improving resolution and long-term reliability. That's a 5 to 15-year horizon for meaningfully better devices.
And for the enhancement applications, the AR overlay, the augmented vision for healthy people, that's much further out. The biocompatibility and safety data required to justify implanting devices in healthy people who don't have a medical need is a much higher bar. And the engineering challenges of producing high-resolution, full-color, stable visual overlays through retinal stimulation are still largely unsolved. I'd be cautious about any timeline shorter than 20 to 30 years for clinically approved enhancement applications, and that assumes continued progress on all the technical fronts we've discussed.
So we're not going to be getting our Terminator HUD implants anytime soon. Not anytime soon. Although it's worth noting that the Terminator HUD is actually a useful reference point for what the field is aiming at. A seamless overlay of information on the visual field that feels natural and doesn't interfere with normal vision. That's the design target. The gap between that target and current technology is still enormous, but the direction is clear.
I love that we're using Terminator as a legitimate engineering benchmark.
Science fiction has always been a useful design brief for technology. The Deus Ex games, Ghost in the Shell, even older works like William Gibson's Neuromancer, these fictional visions of augmented perception have shaped how researchers and engineers think about what they're building toward. The SKYGATE concept itself has that quality. It's a framing that acknowledges both the technical reality and the larger vision of what this technology could become.
All right, so when you step back from all of this, the engineering challenges, the medical applications, the philosophical implications, what's the thing that you think people most need to understand about where this field is going?
I think the most important thing to understand is that the SKYGATE evolution is not a single technology. It's a convergence of multiple fields that are all advancing simultaneously. Materials science, wireless power transfer, neural signal processing, AI-driven image understanding, biocompatibility research, all of these are progressing independently, and the ocular implant field benefits from all of them. Progress in any one of those areas can unlock progress in the others. That's why the pace of development, while still slow by consumer tech standards, is actually accelerating.
And the medical need is real enough that there's genuine motivation to push through the regulatory and engineering barriers.
Absolutely. And I think that's the other thing worth emphasizing. The primary driver of this field is not the enhancement application, even though that gets more attention in popular coverage. It's the millions of people living with progressive vision loss who have no other options. That human need is what's pulling the research forward, and the enhancement applications are, in a sense, a downstream consequence of solving the harder medical problem first.
Here's what this really comes down to, I think. We've been talking about the Skygate as a concept, as an engineering challenge, as a philosophical shift, but at its core, this is a story about the human relationship with perception itself. The eye has always been the window through which we experience reality, and what the Skygate evolution is proposing is that we can open that window wider, or change what's on the other side of it, or eventually choose what we see in ways that were previously unimaginable.
That's exactly right. And I think that framing helps clarify both the excitement and the caution that should accompany this field. The ability to restore vision to someone who has lost it is one of the most profound things medicine can do. The ability to augment perception in ways that go beyond natural human vision raises questions about what it means to be human, about equity, because these technologies will not be equally accessible, and about the nature of shared reality in a world where different people may literally be seeing different things.
The equity point is one I want to make sure we don't gloss over. Because if ocular enhancement implants become available and they're expensive, you could end up with a world where wealthy people have literally augmented perception and everyone else doesn't. That's not a small thing.
It's a genuinely serious concern, and it's one that bioethicists are already raising. The history of medical technology suggests that new devices are almost always expensive and inaccessible at first, and then become more affordable over time. But over time can mean decades, and in the interim, the gap between those who have access and those who don't can be profound. If ocular implants eventually confer significant cognitive or perceptual advantages, that gap becomes a form of inequality that's literally built into people's bodies.
Which is why the regulatory and policy frameworks around this technology matter as much as the engineering.
Completely. And that's a conversation that needs to happen now, while the technology is still in early development, rather than after it's already deployed and the inequities are baked in. The Skygate evolution is moving fast enough that the policy conversation needs to keep pace.
All right, we started this conversation with the image of blinking and seeing a navigation arrow appear in your visual field. And I think what we've established is that that image is both closer and further away than it seems. Closer because the foundational science is real, the engineering is advancing, and the medical need is driving genuine progress. Further, because the gap between current technology and seamless, safe, high-resolution ocular augmentation is still enormous, and the ethical and policy questions are as complex as the technical ones.
That's a fair summary. And I'd add one more thing. The Skygate concept is valuable precisely because it gives us a framework for thinking about this technology as a whole, rather than as a collection of disconnected engineering problems. It reminds us that what we're building toward is a new relationship between human perception and the information environment. And that's worth thinking carefully about at every stage of the journey.
Well said. And on that note, the next time you blink, maybe think about what it would mean if that blink was the beginning of a whole new way of seeing the world. Thanks for listening to Copilot Podcasts. The gate is open. The question is what we build on the other side of it.